maybe. You heard about BYD cell conflicting? No, but the electric cars can self-conflicting.
Realize.
Good morning, good afternoon, and good evening, everyone. I'm Dr. Aarti Heda. I'm the session host for this very interesting session. I welcome you all to IOC 2024, the 4th International Ophthalmic Conclave Conference hosted by All India Ophthalmological Society. We are in this session going to discuss about thyroid eye disease, new understanding and novel approaches to treatment. We have with us Dr. Tarjini Dave moderating this session. Dr. Tarjini is Associate Director at LV Prasad Eye Institute in Hyderabad. She is a great researcher, academician, and a surgeon. So over to you, Dr. Tarjini.
Thank you so much, Aarti. And at the outset, I'd like to thank Dr. Honavar for allowing us to put this program with complete creative control on it. It's extremely thrilling for me to have Dr. Ganga, who's supported us in getting all the faculty and helped us kind of put up this master session on thyroid eye disease. So Dr. Ganga, as you can see, is in his scrubs all masked up and is in the middle of a surgery. And we pulled him out just for this bit. So Dr. Ganga, if you could just get us kick-started and then we'll take the session forwards.
Sure, Tarjini. Thanks very much. And to you, AIOS and Santosh as well, Dr. Aarti. The purpose of this webinar is, as I mentioned earlier on, to really get a global perspective to a very complex pathology, which is thyroid eye disease, which involves every single ophthalmologist and immunologist and endocrinologist, so on and so forth. And we have nothing but the best in the world here today to share their perspectives in the form of lectures, case discussions, and the expert discussion as well. So a warm welcome to each and every one of you. Thank you very much for accepting our invitation and for waking up at the wee hours to share your perspective. Back to you, Tarjini.
Thank you, Dr. Ganga. So as Dr. Ganga mentioned, we have stellar faculty today with us for this session, which will cover topics related to thyroid eye disease. Thyroid eye disease, as you all know, is a disease with myriad presentations and a lot coming up in terms of treatment options for physicians. I'm going to keep the introduction for every faculty at the beginning of the talk to kind of keep it a little more personal. As Aarti has mentioned, we are going to stick to our time. We have talks in the beginning that are of 10 minutes duration, followed by 4 minutes of discussion. And then we have 3 cases which are going to be presented by 3 upcoming bright faculty in ophthalmic plastics, which are of 3 minutes duration, followed by 3 minutes of discussion. So I request all the speakers to kind of stick to this time. The very first talk that we have is on evolving molecular and cellular pathways in thyroid eye disease. And this is going to be presented by Dr. Colin Waller. Dr. Waller is an assistant professor at University of Rochester, New York. His current research interest is in understanding the key molecular and cellular pathways involved in thyroid eye disease. For the discussion of this case, we have along with me Dr. Elon Kahana. Dr. Kahana, born in Israel, grew up in Connecticut, is a professor in ophthalmology and ophthalmic plastic surgery and the vice chair for academic affairs in the Department of Ophthalmology, Oakland University. He is also an internationally renowned expert in orbital and ophthalmic plastic surgery. He's a much sought after lecturer and a respected leader in our field. Welcome, Dr. Kahana and Colin. And Colin, the stage is all yours. You can share your presentation and we can get going.
Okay, I'm hoping my screen is able to be seen here. It's great to be with everybody. And thank you for the invitation. And I'm excited to talk about some of the up and coming molecular and cellular pathways that are manifesting themselves as we look at this disease. Okay, so I don't know how much of an introduction this disease needs for this audience, but we'll just walk through a few things. right? This is the most common orbital disease that we see, and it affects around up to 50% of patients with Graves' disease, which is, of course, an autoimmune disease with anti-thyroid stimulatory hormone receptor autoantibodies. It can affect other people with other diseases, including Hashimoto's thyroiditis, where you have hypothyroidism. But the majority that we've seen are Graves' patients. Some of the risk factors for developing TED are increased age, smoking, which happens to be the biggest modifiable risk factor. We also see in some studies that we can have some nutrient deficiencies, including selenium and vitamin D. We also see that there is evidence of microvascular disease contributing to the development of the disease. And of course, with Graves' disease, it's more common in females, but there does seem to be males having more severe disease phenotypes, as we see. And ultimately, there are many different signs in this heterogeneous disease. You could have mild irritation of the eyes, swelling, proptosis, as we see in some of these examples here, and also optic neuropathy, double vision, and in severe cases, you can see loss of vision. Okay, so now we're moving into some more of the pathological findings here, and we've got some CT scans of an unaffected individual, and you can see here the optic nerve and the orbital space behind the eye. But then I'd like to point out the disease can really manifest itself in a couple of different ways, and we can see here where we have this large, which almost looks void space. This is mostly fat tissue surrounding the optic nerve and really compressing upon this. And we see this signs of proptosis, or the eyes are actually bulging out. But the disease can also manifest itself with a more fibrotic phenotype. And this is where you can see this more dense muscle tissue manifesting here, right? Compressing the optic nerve. So we can see that the disease, just from this, some CT scans, it can manifest itself in a couple of different ways, which really, adds to the complexity of what's going on at the molecular and cellular levels. So here, I give this slide as sort of an example of how the disease might progress. But of course, the disease doesn't always progress this way. This is another reason that this disease has really perplexed scientists and clinicians as we've learned about it. Of course, we do know that one of the main things we see are TSHR autoantibodies that seem to be as an autoimmune disease. These are very prevalent in patients. And then often we'll see an active phase of the disease, which is really characterized by immune cell infiltration and inflammation, production of cytokines in the orbital space. And this often leads to orbital tissue remodeling. And again, this phase of the disease can be heterogeneous itself. You can have dramatic tissue remodeling. The remodeling can manifest with additional lipid accumulation and fat, or muscle and scar tissue as well. And in fact, there are cases of presentation where we do not see this active phase of inflammation, but we still see this heterogeneous tissue remodel, right? So there's a lot going on with the disease, and with that, of course, being able to treat it is a really important aspect. And traditionally, the disease has been treated with some of these three large therapies, namely steroids, obviously to combat the inflammation and try to minimize that tissue remodeling. Radiation has been tried as well. And then ultimately, a lot of times these patients will need surgical decompression of the orbit to remove that excess tissue. And just sort of realizing that these standard therapies are aimed at controlling the disease, and they're not really targeting or curing it. And that's because of the complexity behind the disease and the heterogeneous nature. So while we're all, able to use these to control the disease, we need additional therapies. And really that's, one of the reasons why we're having this talk today, and I'm sure we'll hear more about these exciting new therapies, and I'm going to talk about a couple of them. Before I get into that, I just want to mention how my lab really studies the disease. So we often take surgical decompression of the orbit, which is removed from the patients, and we actually can then look at either gene expression analysis, histology, or immunostaining to kind of characterize those cells and players in the tissue. And one of our strongest methods that we use a lot is actually we isolate tissue explants from this tissue, and we grow out orbital fibroblasts. And with these methods, we can actually study gene expression profiles, cellular players, and potentially new pathways that are involved in thyroid eye disease to make discoveries, to understand more about the disease, and hopefully identify novel treatment methods. So using these techniques and the state of the field has really been able to present these things, of course, not just in our lab, but many other labs have shown some really exciting findings using these types of methods to show that tissue remodeling in thyroid eye disease is a result of multiple cellular players. Of course, we have the immune cells that I was talking about earlier, including B cells, T cells, macrophages, mast cells, and others infiltrating into the orbit and producing various cytokines and mediators to activate these cells' orbital fibroblasts. And these activated orbital fibroblasts can then go on to form other types of cells, including adipocytes, which we often see in that lipid accumulating phase, or they can produce these scar-forming myofibroblasts. And they also produce their own inflammatory mediators. So we have lots of interest in sort of focusing in on these players in the middle of this field here, where activated orbital fibroblasts. And so just to highlight, you work with fibroblasts, and we people know about them as being structural cells, but they're really much more than that, right? They are really actually part of the immune system, providing structure, but also responding to many of these different activators. Fibroblasts themselves can come from a variety of sources. They could be resident in the tissue. We actually have these bone marrow-derived circulating fibrocytes that can infiltrate the orbit and become like these fibroblasts. Otherwise, there are stem cells, and epithelial mesenchymal transitions can also form these stromal fibrotic cells. They are often heterogeneous in their population. They express multiple surface receptors that could then sort of act as these sentinel responders. And they do differ by tissue source. And this is just an example of these orbital fibroblasts, which express the IGF-1 receptor and the TSH receptor. And they can be activated by various mediators to produce extracellular matrix like hyaluronin and collagen, again, increasing the tissue in the orbit. They can also form these myofibroblasts or lipid accumulating cells, and they themselves can produce further cytokines and chemokines to activate the orbit. Okay. And here's just an example of some data I wanted to show that, fibroblasts from different tissues are actually distinct. Here's an example of some subcutaneous fat fibroblasts, and we're looking at expression of the insulin-like growth factor 1 receptor, IGF-1. And you can see that in the TED orbital fibroblasts, we have a elevated expression of this receptor. And that's a very significant difference in some of these fibroblasts. And you can see some other markers of fibroblasts. I'm just showing as an example here. And what we know, so we have this elevated level of IGF-1 receptor in these orbital fibroblasts. And it turns out that going back to sort of the main autoantigen in TED, the TSHR, it does seem like these two receptors can actually form a complex and lead to further activation of these fibroblasts, including stimulating proliferation, extracellular matrix production, and what we see, the manifestation of the disease. So that really leads, of course, to the really recent success of teprotumumab, which is a blocking antibody against the IGF-1 receptor. It was originally developed for cancer, but it was found because it blocks the IGF-1 receptor, and IGF-1 receptor is elevated in orbital fibroblasts and really leads to the signaling. It was tested in this, and there was some really remarkable success with this compound. It does, from the clinical trial that was published a few years ago, we can show that it reduces proptosis, bulging, and lid retraction. So some really exciting results when we block this pathway. This is a great advance, and it reveals that TED can be targeted therapeutically, so with a specific target. But there are some drawbacks, like there are with any therapy. So we'd like to, continue our search for new therapeutic targets and potentially new therapies for the disease. And that's where I'd like to just draw your attention to just two things that our lab has really been working on, and that's this receptor called the aryl hydrocarbon receptor. It's a ligand-activated transcription factor. It was actually the first reason we looked at it was because components of cigarette smoke can actually activate it. And we know that smoke is the most significant modifiable risk factor for TED. And so we started to look at that. But what we found was that TED actually has, or that the aryl hydrocarbon receptor has multiple different ligand classes. And while it does bind to these toxins, it also binds to these short-lived tryptophan derivatives, including some components that are generated by microbiome. And what we found was that actually these tryptophan derivative ligands can actually prevent myofibroblast formation in orbital fibroblasts. We're just showing here again that the addition of a cytokine that's often elevated in TED, transformer growth factor beta, which causes these cells to form these smooth muscle actin positive myofibroblasts. But if we give these cells aryl hydrocarbon receptor ligands, we can actually block that expression unless we get rid of the AHR through genetic interference, short interfering siRNA. When we get rid of that, these ligands no longer work. So we know that this is an AHR-dependent process of actually preventing myofibroblast formation. Now, it turns out the AHR has multiple ligands, and another class that actually activates this receptor are proton pump inhibitors like esomeprazole. And in fact, we did see remarkable inhibition of myofibroblast formation when we treated the cells with this, already used drug, esomeprazole. To switch just to the other side of the equation, just really quick, I know my time is up and pretty soon here. We also have looked at the other side where we're trying to block lipid accumulation. And we have shown that there are other activators like prostaglandin J2, which increases the adipogenesis of these cells, increases lipid accumulation. And in fact, we found that T cells can actually produce this mediator driving adipogenesis and lipid accumulation. And we looked into this AMP, adenosine monophosphate activated protein kinase, which is sort of a branch point in metabolism. And using these activators of this receptor, or of this kinase, including ICAR, which is the precursor to adenosine, and metformin, another used drug. If we activate this receptor, we should be able to prevent adipogenesis in these cells. And in fact, that's exactly what we saw. So when we treated these cells with either metformin or ICAR, we can prevent that lipid accumulation. So we could block this activity in the fibroblasts. So I know I kind of raced through those, but I just like to kind of highlight that these are some of the things we're looking at. We know that the success of teprotumumab is very exciting, but we do think that there are other pathways that are contributing to this disease, and we'd like to find new ways to target them. And that's some of the brief examples I wanted to show in this talk. So we really went through pretty quickly, but AHR ligands can block this myofibroblast formation. And on the other side, AMPK activators can block lipid accumulation. And just thinking about, could these be additional treatment options for the disease? And with that, I'd just like to end my talk and thank everyone for listening. And yeah, I'm over here in upstate New York right now. This is the lab and Flom Eye Institute. So again, Thank you very much, and thank all of the members of the lab and collaborators that I have. And I'd be happy if there's time to take questions.
Waller, that was Colin, that was fantastic. For me, it was new knowledge to learn about the AHR ligand as well as the AMP activated protein kinases, the first to inhibit the formation of myofibroblasts and second to reduce adipogenesis. So that's very exciting to know. I'll let Dr. Kahana go ahead and have the discussion, and then we'll open it up for questions.
Very good. So thank you for the opportunity to participate. I'd like to congratulate Dr. Waller on a very good presentation. Thyroid eye disease is a strange disease in that some patients have it and other patients don't. Some patients manifest with just retraction and others have proptosis, but no restriction of motility, and yet others have restriction. You can have one side be highly affected and the other side of the same patient have a very limited disease. And so the fact that it can be so asymmetric tells us that there are local tissue factors that must be involved, not just circulating factors. Dr. Waller focused his talk, he obviously mentioned all the different pathways, but focused his talk on cell tissue mediators, cell biology, where the tissue can regulate local interactions and affect the local fibroblasts. I think of the disease as having a few different pathways. One is the autoimmune pathway that involves things like interleukins and MCP1 and the TGF-beta, and those are in many situations the triggers. That is the autoimmune process. That is, when I talk to patients about it, I say that's rheumatoid arthritis of the orbit. It is an autoimmune process, but that's the trigger. And then you have the endocrine process. I think of the IGF-1 receptor pathway as being part of that. It also includes TSH receptor. And as Dr. Waller mentioned very early in his talk, what we do as clinicians is try to address the risk factors, and especially the modifiable risk factors. I can't make an old person young, and old people have a risk factor for the more fibrotic disease, but we can affect their vitamin D level. That's a molecule, it's a nuclear receptor ligand that is a transcription factor that regulates local tissue responses. We can affect smoking, and we can affect TSH receptor. So TSH elevation, let's say someone underwent radioactive iodine or thyroidectomy, and their TSH now is, or their thyroid is inadequately reinstated, their TSH is going to go up, and that's going to activate the IGF-1 receptor, TSH receptor pathway, and stimulate the local biology that then leads to the hyaluronan and collagen cross-linking, etc. And then Dr. Waller really focuses on the local response to these triggers, the endocrine triggers and the autoimmune triggers, because then the disease takes on a life of its own. And even once you remove the triggers, it takes a long time for the orbital disease to change course, because you have these local pathways, such as the AHR pathway, the PPAR gamma pathway, the AMP kinase pathway. And what's really, for me, promising about studying those pathways is that it will, one, allow us to understand why one orbit may have a different response from the other orbit. And two, is it will allow us to engage in local therapy, where potentially in my practice, I inject steroids, I inject 5-fluorouracil, because those are tissue modifiers. And Dr. Waller's research can hopefully identify additional tissue modifiers that will allow us to acutely treat severe forms, progressive forms of the disease by targeting these pathways. So again, I'd like to congratulate Dr. Waller for doing basic and translational research with a keen understanding of the unique features of this disease that impact so many of our patients. Thank you.
Thank you, Dr. Kahana. Yeah. Colin, just a short question while I request Dr. Dolman to load his presentation. As Dr. Anya Exton also mentioned or has written in the chat box, all of the treatment options that we are talking about in terms of blocking the myofibroblast or preventing the formation of adipogenesis should ideally be in a situation where you prevent the disease. After the disease is manifested, these might not have much role. So clinically, would there be markers, or serologically, would there be markers which could kind of guide you that what is the final presentation or phenotype of thyroid eye disease going to be in a particular individual?
Yeah, that's a really great question, and I saw the question in the chat. I was gonna type it up, but yeah, I think you know, these compounds that we're testing in our cultures are really, you know, at the remodeling phase, at the tissue remodeling phase, and sometimes, you know, of course, we'd like to treat the disease earlier to sort of limit that remodeling. And you know, based on potentially the CT scans or imaging, if we could see if the patient has, you know, that severe fibrotic type disease or a more adipogenic type disease where you have that fat tissue, that could be where we start to think about these differential treatments in terms of the patient's phenotype. And yeah, the treatments that we're using, we sort of think of them as modeling later type disease. However, you know, the role of some of these soluble mediators, you know, could be at those earlier courses of the disease too. So there's potential to treat this at different stages too. So yeah.
Thank you, Colin. With this, we'll move on to the second talk, which is updates on imaging in thyroid eye disease. Again, it's my distinct pleasure to have Dr. Peter Dolman join us for this talk. Dr. Dolman is the Director of Ophthalmology Fellowship Programs at University of British Columbia, and also the Division Head of Oculoplastics and Orbit. He has served as the past president of the International Thyroid Eye Disease Society and is a member of the Orbit Society, which is an international consortium of orbital experts. Dr. Dolman, it's so good to see you here, and thank you for being here despite the crazy schedule that you've been through, and despite all the difficulties you had, as we discussed on mail. So along with Dr. Dolman's talk, we have Dr. Suryasnath Rath, who's going to moderate the discussion for this talk. Dr. Rath is a colleague at the Bhubaneswar or the Mithu Tulsi Chandrai campus of LV Prasad Eye Institute. He's mentored that campus and currently serves as the Director of Operations for the entire LV Prasad Eye Institute. Again, an expert in thyroid eye disease, and I'm very pleased to have the both of you here for this talk on imaging. Dr. Dolman, it's all yours.
Oh, thanks very much, Tarjani, and for inviting me to participate. I apologize. I think my talk may be a couple of minutes long, so I am going to try to speak fairly quickly. We heard from Dr. Waller how thyroid eye disease is an immune-mediated inflammation that causes enlargement of the orbital fat and muscles, and that this leads to a broad spectrum of clinical manifestations that can leave the patient with significant visual and cosmetic morbidity. We like to assess both disease severity and activity in order to manage the disease properly. And disease severity refers to what specific tissues are targeted and how badly that affects their function. We heard about the lipogenic variant or type 1 variant in roughly 2/3 of patients. This causes fat expansion, quite often associated with levator muscle scarring, leading to exposure, typically seen in younger females without a family history necessarily. And fortunately, this variant often doesn't have severe ocular morbidity. At the other end of the severity spectrum are those that have more targeted myogenic or myopathic disorder. with the swollen muscles causing congestive or inflammatory signs. If they become tight, they cause restricted motility and strabismus. And if they compress the nerve, can lead to optic nerve compression. And this phenotype's most commonly seen in older males, often smokers. It's really the latter variant, the myopathic group, where the biphasic disease course is more apparent. During an active or progressive phase, as the severity worsens, the introduction of medical or radiotherapy is hoped to reduce the sequelae. And it's only once the disease is in the inactive stage that surgical rehabilitation is considered. I'm going to focus on primarily CT and MRI scans in thyroid eye disease, as these are most commonly used. But I will mention in passing that ultrasound is popular at some institutions for measuring the recti muscles and their enlargement. Color Doppler is interesting to study how the vasculature dynamics changes in the orbits. And there's a nice paper by Dr. Dave on facial thermal imaging, which you might want to comment on later in its correlation with clinical activity scores. I'm going to review the pluses and minuses and different scan images that you can obtain and how we can apply it to help with diagnosis and differentials, distinguishing fat versus muscle phenotypes, assessing aspects of disease severity and activity, and in surgical planning and assessment. Well, CT scans have been around since the 1970s. They create 2D images of radio density, and our newer models are very fast, have low doses and improved resolution, so that they provide rapid acquisition with little motion artifact. For me, it's my first choice for orbital trauma, tumors, and thyroid eye disease. I particularly find it valuable because it shows bone detail for surgery planning and post-op. But you have to recognize its limits. It does expose the patient to radiation. It's not as precise as the MRI in soft tissue distinction and resolution, and also in terms of inflammation and edema in the soft tissues. Safety issues, young children, I think we try to avoid CT scans, or at least repeat CT scans in case the radiation is detrimental. And remember, the contrast can induce a nephropathy, so we have to hydrate the patients well, and patients on metformin should discontinue it because of the association with lactic acidosis. Well, what are the different views? I find I like the axial view, particularly in the horizontal muscle and optic nerve plane. To sort of categorize the patient as being in the fat or more muscle phenotype. And in addition, you can draw a line between the zygoma and the anterior lacrimal crest. And there's a general rule that if the equator lies behind that point, it's less likely to be a proptotic eye. If it's pushed beyond that point, it's more likely proptotic. Of course, there's variations, but I find this view gives you a sense of the proptosis that you may not actually recognize in clinically looking at the patient. I'm going to mention here volumetric analysis. There's a number of interesting papers that manually have taken each slice and outlined the areas of the muscles and optic nerves and the areas around the bony volume. And by subtracting the soft tissue, the muscle and nerve, and the globe, you can calculate the area fat volume. And that's, I think, interesting, at least at this stage, from understanding some of the pathogenesis and some of the dynamics of the orbit in terms of them. I think increasingly the programs and perhaps some artificial intelligence program maybe allow us to do this more precisely and without the labor involved. On coronal views, I'll emphasize a couple of views that you should pay attention to. Anteriorly, at the point where the superior rectus is just inserting into the globe itself, I find that gives a good view of the aponeurosis transition to the levator muscle. And that highlights enlargement or contrast enhancement or infiltration, distinguishing the muscles and pointing out that the levator is targeted by the disease. And this is often missed by most radiologists who are interpreting them, and easy to miss unless you look specifically. So pay attention to this view. And posteriorly near the apex in the coronal view, it's nice to look at how the optic nerve might be compressed by the enlarged muscles in this patient's left eye. Sagittal views I don't look at so much, but this gives you some idea of what a post-op decompression looks like, involving the floor in this case. And it's kind of interesting to correlate that with the clinical images pre and post-surgery. Contrast enhancement, I think it can help identify activity in thyroid eye disease. And CT scans are actually quite interesting when you have enlarged muscles. This patient initially had disease 20 years previously with optic compression from swollen muscles. And you can see now 20 years later, they've got this lucent sort of lacy appearance, presumed hyaluronic acid deposition, but no contrast enhancement. And when the CT was taken, he just had the onset a few months back of progressive protrusion and swelling of his muscles. And you can see the edema and contrast uptake in this case. So I think this is interesting to study and compare with MRI studies in terms of correlating it with activity. Magnetic resonance imaging is 3 parts, as suggested by the name. First, strong magnets force the spinning hydrogen protons to align with the magnetic field. Once those hydrogen protons in the tissue are aligned, a radio frequency pulse is shot at it, or shot at the patient. The protons absorb the energy and shift their axis. And the image is gained when the radio frequency is stopped, and sensors detect energy release as the proteins relax back. The benefit of MRI is that, as I mentioned, it's better for soft tissue analysis. I think is probably better than the CT contrast to study thyroid eye disease, edema, and muscles. And it's nice there's no ionizing radiation and less safety issues, but it's longer to perform, it's more expensive, it's very claustrophobic if you've ever been in the MRI tunnel, and you have to be careful about metal, foreign body, or medical devices. And it doesn't really give you any bone detail because bone appears black on the MRI. So I find I can't plan surgery quite as easily in my head. I've mentioned already the metal devices. Gadolinium is an important adjunct, which is very useful in increasing the signal in T1 weighted images and highlights neoplasia and inflammations, and again shows edema better in muscles that have recently been expanding. Remember also gadolinium is associated with sort of a scleroderma type syndrome rarely, so renal function should be assessed. The T1 relaxation phase tends to show fat very bright, as shown here, and the water is closer to black. The T2 relaxation phase shows both water and fat as bright, And so fat suppression, digital subtraction of the fat signal is often performed to enhance contrast or enhance distinction when looking in the orbit. So you can suppress fat in both this T1 image. This one has had the fat signal suppressed, and then it's had gadolinium. And so gadolinium enhanced T1 with fat suppression is quite valuable at studying tumors and potentially edema and thyroid eye disease, highlighting the muscles. Many people like the STIR sequence, which again uses a fat suppression technique, but highlights edema. And the paper published in 2019 introduced the concept of comparing the signal intensity in the orbital extraocular muscles with the adjoining temporalis muscle in order to predict if it's brighter than that muscle, whether that correlates with CAS scores. So let's look at specific indications. One is to confirm the diagnosis. Remember, diagnosis of thyroid eye disease is based on clinical findings, the thyroid lab testing, T4 and antibody tests, and imaging. So it's the third arm. And what we look for, I've already partially mentioned, lid retraction. We look for signs of the swollen levator muscle. If someone's got a proptotic eye, we confirm that these look like thyroid enlarged muscles with proptosis. Notice the sparing of the tendons. There are differentials for the swollen extraocular muscles. Sometimes you can figure it out clinically, but imaging is often a very helpful adjunct in helping you. For example, in this acute myositis, look how her medial rectus muscle is swollen, and typically the tendon is involved in the enlargement. IgG4 disease can also cause muscle involvement, and here we often get clues because other tissues in the orbit are involved, like these bilateral lacrimal glands or this supraorbital enlargement on both sides there. I find a lot of patients with dural fistula are referred into me as thyroid eye disease. It's not that that happens often, but I find more people are sending in dural fistulas with the diagnosis of thyroid eye disease than dural fistula. I mean, it's often obvious on clinical examination, but it's very helpful. Here you see the swollen muscles. It's helpful to see the enlarged superior ophthalmic vein, distended cavernous sinus. This is a color Doppler showing the shift in flow back to the superior orbital vein. I'll mention upper lid retraction. I showed you already. I'm sorry, I don't know if these pictures are they blocking the view? Okay. I've shown you already how the levator muscle is typically enlarged on the side with the lid retraction. Dr. Mike Davies, who was a fellow and now in Sydney, authored a very nice paper, or an interesting paper, I should say, where we independently judge CT scans on patients with asymmetric lid retraction. And we found we were both 90% accurate at predicting which eye was the retracted eye on looking at these views of the CT scan. Another feature to notice on the CT is the contrast enhancement, which suggests it's recent disease. You can see patients with older lid retraction, and it turns into that same lacy pattern that you see in the extraocular muscles. And Surya, who's going to be commenting later, just did a very nice review on MRI imaging looking at contrast enhancement and whether that predicts whether Kenalog injections might work better. Here we just elevated her lower lid and lowered her upper lid. And I'll focus as well on severity to thyroid optic neuropathy. I did a review on about 80 patients with optic neuropathy. Again, imaging is quite nice at highlighting the 95% that have compressive changes at the apex, but there is a subset of 5% who have optic nerve stretch. And clearly here, tenting is a bad sign for permanent vision loss. But here it's not apical decompression we're trying to do. We need reduction in proptosis to try to reverse the vision loss. We also, in that review, noted optic nerve sheath distension was correlated with poor visual acuity. And also this feature that others have, like Don Kakawa, have noted, that following decompression, often the swollen muscle will continue to expand if you're not careful and prevent this with radiotherapy or steroids. And if it expands, we had, in my series, I had 20% of patients who had excellent vision following surgery and started deteriorating again. I'll finish by talking about surgical plans and assessment. I think imaging is very useful in preoperative planning. Let's say for orbital decompression, studying the bone fat anatomy will influence your surgical approach. It can help identify hazards like the presence of sinusitis or a low cribriform plate that might be prone during a medial wall decompression. Strabismus timing may be delayed because of contrast enhancement on CT or MR evidence of edema and possible activity. And where the enlarged muscles are may influence your decision. Maybe Alon will talk about navigation surgery. I tend not to do this much, but it's certainly popular in some centers for, let's say, optic nerve or orbital decompression for optic nerve disease compression. So for enhanced apical decompression or reops, that's a nice tool. And postoperatively, I think if you do get images, look at them carefully to self-evaluate how well you did different aspects of the project, how the tissues change, like those muscle enlargement following this decompression, and any complications that may arise. In my view, I think these imaging studies are very helpful adjuncts to the clinical assessment for diagnosis, evaluation, and management. But I don't know that at any point now I would say that I would depend entirely on an imaging or that it was superior to the clinical assessments. As I still think clinical assessments are first choice in assessing activities, the severity parameters, and the diagnosis. And there are research applications, many papers looking at different signals from MR scans, looking at those volumetric analyses and creative things like facial thermography, trying to understand the pathogenesis. Maybe artificial intelligence programs will be able to take a series of patients with variable course and use them at some point to generate more predictive models. Thank you very much. I'm sorry if I went over.
Thank you, Dr. Dolman. Surya,
yeah,
short of time, but we'll take your conclusions on the imaging.
Yeah. Thanks, Peter. You almost covered almost everything that's important from imaging, how imaging help in thyroid eye disease. Just a couple of comments. I think one of the reasons why imaging seem to be becoming more and more important is we want to understand about, or rather, we want to have a clearer idea about the window of opportunity that they offer in understanding the deeper orbit and also assess the activity of the disease. We always had the clinical scores, but they seem to be sometimes confounding. Like in my practice, when you have a corneal breakdown with microbial infection, you don't know which one is the soft tissue inflammation for. Having said that, I think several parameters have come in. The signal intensity ratio talked about has been there for some time, has helped not only in retraction, but also in intraorbital steroids. The T2 relaxation and the T1 relaxation times. I think key things that are important for the future are to understand whether the assessment based on imaging can precede the clinical activity scores that we know. There seem to be a few papers related to that. Number two is we already know that when assessment of the activity is done on imaging, they seem to respond with therapy. They seem to show a response too. So that seems to giving us a sort of a something to look out for, whether it is helping the patient or not. And again, also in some situations like the dysthyroid optic neuropathy, where the diffusion tensor imaging or the diffusion weighted imaging has come in handy. That's all I have. Thank you.
Thank you.
I'll comment very quickly. I entirely agree that both the CAS score has false positives and negatives and is easily confounded. You know, the ITEDS visa way tries to just base activity based on progression of any of the severity signs, but it's limited as well because you basically just conclude that it's active because one of the severity things has progressed historically, but it doesn't give you a number that you can work with or something that's easily used in research. So it would be wonderful if imaging was helpful. One thing I've found a bit puzzling is that most studies that want to prove that a particular imaging feature is correlated with activity as they compare it to a clinical activity score. And I think we're trying to actually, you know, we're trying to find something better than the clinical activity score. We should really compare it to disease outcome or disease course or something tangible like this indicates the muscles become enlarged or this indicates that strabismus develops. So I think it would be nice in future if any prospective study looking or retrospective study even looking at imaging could compare to something other than just a CAS score.
Thank you, Dr. Dolman. For the want of time, we'll...
Tajani, I have to say something.
Yes.
In response to this talk, I just want to remind everybody that using iodinated contrast in patients with thyroid eye disease is contraindicated medically, can cause severe worsening of both the thyroid disease with thyroid storm and of the thyroid eye disease. And I highly encourage people to use MRI and not a CT scan with contrast. I have no problem with CT, but iodinated contrast is medically contraindicated in anyone who has active thyroid disease or thyroid eye disease. And you can actually severely worsen the disease in these patients because of the iodine.
Right. Great point, Dr. Kahana. Thank you very much, Dr. Dolman. I appreciate the effort you've taken to take us through the talk on imaging. We now have with us Dr. Timothy Sullivan, who's going to speak to us on the first line medical management, steroids or targeted therapy, probably something that all of us want to know the answer to. Dr. Sullivan from Brisbane, trained at the Moorfields Eye Hospital in London, and also in pediatric ophthalmology at Toronto at the Hospital for Sick Children. He has been on the board of the ITEDS and has also been a former president for the Australian and New Zealand Society of Ophthalmic Plastic Surgery and also the AP-SOPRIS. Dr. Sullivan, the stage is all yours. I have with me for discussion Dr. Stephen Couch from the Washington University Physicians. And we all know him from the AAO subspecialty day fame, which works with clockwork precision with fabulous content that they bring across to us. We have the stage set for Dr. Sullivan with his talk and Dr. Couch for the discussion. Thank you very much.
Thank you. I'll just try and share my screen. Okay, so I'd like to thank Tajani, Ganga, and the All India Ophthalmological Society for organising this symposium and inviting me. I've been given the somewhat difficult task of talking about steroids and comparing them with targeted therapies. And as we've seen so elegantly demonstrated by Colin, the pathogenesis is very complex, involving fibrocytes, T and B cells, IGF-1 receptors, and a whole range of interleukin inflammatory cascading molecules, the CD40 ligand, and all of these are potential targets which, in addition to steroids, brings up the possibility of using monoclonal antibodies, various cytokines, and exciting new agents in small molecule antagonists. And this all came about from, several decades of research into the treatment of rheumatoid arthritis. So our pathogenic pathways mean that we can have intervention all the way along, whether it's for the dendritic cells with IL-6 and tocilizumab, teprotumumab, small molecule antagonists, rituximab, CD20. So there are plenty of sites that we can attack this. But probably the main ones we need to look at today are rituximab, tocilizumab, and teprotumumab. There are a range of what I will call the new kids on the block, and I've just modified my talk in the last sort of couple of minutes to add in aryl hydrocarbon receptor ligand and activated protein kinase signaling. So thank you, Colin. But also M22, the biological process of autophagy, connective tissue growth factor, and CFZ533, which is a CD40 antagonist. So all of these things hold promise, but they're not yet ready. And in context, I think we need to look at what are the accepted approaches. And there was recently a consensus statement by the joint consensus statement by the American Thyroid Association and the European Thyroid Association, looking at steroids, and that they still regard this as being first-line management, that IV glucocorticoids is a preferred treatment for active, moderate to severe thyroid eye disease, as long as you follow a regular dose pattern without exceeding that. Things should be relatively safe, and we would expect a 60 to 70% response. But where there is a poor response after 6 weeks, they recommend considering other treatments. And of course, not getting into the high dose of steroids where you could have hepatic or other potentially fatal complications. This is one of my patients who had the 500 milligrams of steroids weekly for 6 weeks. And yes, there's a bit of a reduction in the inflammation, but we're not really seeing a disease modification, which is our target. Alon mentioned the use of 5-FU and triamcinolone intraorbitally. There's been a recent publication in OPRS about this, so there is promise. And I certainly do use this for eyelid retraction, and this is highlighting the levator enlargement that Mike Davies and Peter Dolman were just talking about, and the good response you can get to steroids with that. The targeted therapies, however, in the combined consensus statement, suggest that rituximab and tocilizumab may be considered in steroid-resistant patients, and that Ritux is acceptable in patients with active, moderate to severe disease, and again, tocilizumab, the same thing, where patients are glucocorticoid resistant. And interestingly, their consensus statement, which was in 2022, says that teprotumumab is a preferred therapy, and here's the key thing, if available in patients with active, moderate to severe disease. If we move then to the UGOGO guidelines for a consensus, they recommend for moderate to severe disease IV methylpred in combination with mycophenolate. Now, I have a problem with that because in their own study, the Mingo study, where people were randomized to steroids or the mycophenolate, no significant difference was seen in response at 12 weeks with the mycophenolate. And that has been my experience, that this is not a terrifically helpful agent. They then go on to talk about teprotumumab as being very promising, but really the results are pending. I think most people would probably disagree with that now and think that Tepro is established. Rituximab can be considered as a second-line treatment, and the same for tocilizumab. The problems with Ritux are that they had good results in the Italian randomized study, but this was not replicated in Murray Stan's Mayo Clinic study. And that might have been because of the different timing of the intervention with rituximab, but there's still some question about it. And I certainly have had patients who we've given rituximab to, like this gentleman, who had no real benefit from it. On the other hand, our experience with tocilizumab is actually quite pleasing. This has been shown to be of benefit in a majority of treated patients in a number of different studies. And here's one of our patients with huge extraocular muscles who, after 6 months of tocilizumab, had a marked clinical improvement in the clinical activity score, her double vision, and her extraocular muscle enlargement. Moving on to Tepro now, this monoclonal antibody to IGF-1 receptor has had very promising early results, which have been replicated in the landmark double-blind placebo study, which essentially, in a nutshell, showed that 70% of patients who get Tepro improve, compared with about 20% of placebo patients. And these are the photos from the original reports, which show the dramatic improvement below from the Tepro compared with the patient with placebo above. But there are other exciting agents around. M22 is a small molecule TSH receptor antagonist, which has a lot of promise. And ANTAG3 similarly may show some benefit and has had exciting preliminary studies. And the anti-CD40 CFZ533 that I mentioned that Murray Stan is working on also has a role. And I put it to Colin that maybe perhaps his agents will also be of benefit, and I look forward to more studies from that. So in the brief time allotted, I've said that at least in our Australian healthcare environment, where we do not have access to teprotumumab, steroids are still the mainstay initially for treatment. And in steroid failures, we then move to tocilizumab or then rituximab. And one day we might be able to get teprotumumab should it become approved in our area. And other small molecule antagonists are also promising. I'd like to thank the organisers for asking me to present, and hope that this can stimulate a little bit of discussion. Thank you very much.
Thank you, Dr. Tim. That was fantastic. Over to you, Dr. Couch.
So Tim, fantastic talk. I agree. I think there's a couple things to discuss. Number one, there's actually quite a number of trials that are getting ready to start on different other different other drugs that block IGF receptor, but also IL-6 inhibition. These are different IV, subcutaneous, and oral variations of drugs. And so at least in the United States and in Europe, there's going to potentially be other drugs on the market besides the ones that you listed. One of the things that comes up with teprotumumab that anybody that has experience with it that knows is the significant recurrence rate. So yes, 70% of patients have a response versus 20 in the trials. But a portion of those patients go on to have recurrence at about 6 months, 8 months following teprotumumab. So I'm not sure that it's necessarily the end-all be-all drug, and has its probably phenotypes and other aspects of the disease that it might treat the best. And anybody else that has experience with some of these drugs, feel free to pipe in about their experience. But at least in the United States, I've found that rituximab, as following the study by the Mayo Clinic by Mary Stan, has become difficult to get approved. I certainly have very little trouble, surprisingly, despite the cost, getting teprotumumab approved. And I actually don't have much trouble getting tocilizumab approved, but following that study by the Mayo Clinic, I have not been able to get rituximab approved. And so I welcome any other thoughts especially about teprotumumab, if you have had any experience with that.
I might just make a comment on the on the tocilizumab, we've used that in probably about 35 patients now. And really across the board, we see an improvement in their clinical activity score, their imaging findings. And if you look at their either TSH receptor antibody or TSI, they have a significant decrease in their numbers for those antibodies. So I think it works very well. And in Australia, at least, it's available and it's way cheaper than teprotumumab, and it doesn't have the hearing-related issues.
Now, do you use IV or subcutaneous?
It depends on basically what preparation is available. Most of the patients get an IV infusion initially, and it controlled in our internal medicine day therapy unit. And if that is without a problem, then they switch to subcutaneous, and they do it themselves at home on a weekly or fortnightly basis.
I have the same experience with him, and then I've been treated about 20 patients with tocilizumab, and then same result where we can get from the patient TSI and then TSH receptor antibody decrease, and then many diplopia disappeared, but some of the patients did not respond. So maybe good patient respond well, but the other just present. That's what my comment.
Thank you, Colleen.
Following on Dr. Waller's talk, you have the autoimmune triggers, you have the tissue issues. So you need to, I've had good response with the tocilizumab, both sub-Q and infusions. And we just choose patients that our autoimmunity is very active with higher antibody titers, etc.
Right, Dr. Anya had a comment to make.
Yeah, I just wanted to add that you have to look at the phenotype of the disease. If you have more tissue remodeling, tocilizumab may be not so effective, but if you have a strong inflammatory compound, I absolutely agree with Timothy. Tocilizumab is a very helpful drug.
Right. So we've had a great discussion on this topic, and the next topic is kind of in continuation. We've discussed about teprotumumab in the US and tocilizumab and rituximab in the teprotumumab devoid world as of now. So I have with me Dr. Masashi Mimura, who graduated from Osaka Medical College and has also trained at San Diego, who's going to talk to us today on targeted therapy, the Asian experience. And to moderate this talk and to take the discussion ahead, it's a pleasure of mine to have Dr. Kyung-In Woo, who is from Samsung Medical Center and is the current president of the AP-SOPRIS. So the stage is all yours, Dr. Mimura. Thank you.
Thank you very much. Can you see my slide correctly? Okay,
Yes.
So, okay, thank you. Hi, everyone. My name is Musashi Mimura from Osaka, Japan. I'd like to thank the committee and host Dr. Ganga and Dr. Tarjani for including me in the session. My talk is my thyroid eye disease with East Asian perspective. My financial disclosure. Thyroid eye disease is an inflammatory soft tissue enlargement around the eye, result in clinical manifestations such as eyelid puffiness, lid retraction, and proptosis, and potentially causing sight-threatening condition like dysthyroid optic neuropathy, DON, and corneal ulcer. Basically, the severity of TED depends on the grade of inflammation, which may be influenced by receptor status. But on the other hand, it is also influenced by soft tissue character, including skin texture and anatomical position. So as we all know, these characteristics of eye and external tissue are different between ethnic groups, and this can be a factor of the TED prevalence or severity. The AIOS registry of AAO highlights ethnic difference in the TED prevalence and reported that Asian having a lower incidence compared to the white. In this ethnical difference of the tissue, anatomical disparity, such as bony orbit dimension and eyelid feature, can be a candidate for the main factor. So I was an international fellow of Dr. Kikawa and Dr. Cohen in UC San Diego, and they have over 25 years of history in treating TED patients as a specialist group called Thyroid Eye Clinic, consists of 2 oculoplastics and 1 neuro-ophthalmologist. and they have been treating vast number of TED patients in their clinic. So during the fellowship, I was wondering why I did not meet such a big number of TED patients in Japan. So among San Diego population, 16% is Asian. However, there was only a few Asian TED patients compared to the other vicinity when I was in the fellowship. So of course, the difference may be influenced by multi-factors such as smoking rate, food, social insurance coverage, etc. But I thought that the most reason may be anatomical difference. So I looked for the literature and firstly the bony orbit. The anatomical report showing that Asians have a 3 cc smaller orbital cavity, narrow orbital opening, and 3 millimeter reduction in hair cell. So these difference leading that Asians have less eye bulging and have high orbital pressure compared to the Caucasian. Next, regarding the eyelid, Asian eyelid exhibits more pre-aponeurotic fat, thick and tight skin than white, and epiconsal fold. So the eyelid feature also make the Asian orbit tight and leading that TD in East Asian are discrete rather than white. The difference can be referred to the symptom as well. East Asian has a less retraction compared to the Caucasian and tend to have a epidural frown. So from all these aspects, East Asian TD patients can have low profile rather than Caucasian and tend to have high orbital pressure. So East Asian TD may be stealthy manifestation and may lead more likely to maybe have a dome. But there is still controversy in the prevalence of TED. The latest report from Japan showed that the prevalence of TED in Japan is similar or more than US. So this report reminds me that, again, that TED is influenced by multi-factors. One more factor that we need to judge for the discussion is that the enlightenment over TED. In Japan, there has been not many oculoplastics, so that a few surgeons can do orbital decompression surgery. So many patients have referred to neuro-ophthalmologists and treat with non-surgical approach such as IV steroid and radiation. Moreover, this history makes the situation very bad that the healthcare insurance still does not cover the decompression in Japan. So TED patient in Japan eager to have more information and better treatment that I have been referred by many patients year by year. So my opinion now is that prevalence of Japanese TED patient is not less than other country. This is my treatment option for TED patient in my clinic. For active TED, I prefer to inject thorium into deep orbit. And if there is moderate to severe inflammation in extraocular muscle, I will add IV steroid. And in case of DON, I prefer endoscopic medial wall decompression in addition to full dose of steroid use. For inactive TED, basically I prefer microscopic orbital fat decompression. And in case of severe muscle enlargement, I will do the bony decompression. On the other hand, there's an option, Biologic, have been researched for many years, and Game Changer came out about 5 years ago. So as Dr. Sarban said, researchers have been seeking for the biologic agent, including tocilizumab and rituximab, but the teprotumumab, which is targeting IGF-1R, have been focused since 10 years ago. And the clinical study reported dramatic effect, which led FDA to approve it as only agent in reducing proptosis of TED patients. Since FDA approval in 2020, strategy of TED treatment has been changed dramatically in the US. That Dr. Kikao said that the compression surgery have reduced into half than before. This fascinating the agent is now available in 3 countries, which is US, Brazil, and UAE. But in 2024, it may be able to use in Japan as the first country of East Asian population. In cooperation, I cooperate with the study as a coordinating PI for the phase 3 clinical trial in Japan. So I'm happy to share the results here. The first RCT study for the teprotumumab in the US has designed for active TED called Optic, and 83 active TED patients from 11 institutions enrolled in the phase 3 clinical trial. Infusion of teprotumumab every 3 weeks of 8 times was done and compared with placebo. The main outcome parameter of the study was reduction of proptosis more than 2 millimeter, and also diplopia, CAS, and GOQOL was evaluated. So the RCT study in Japan started 2021 called Optic J, and 54 patients from 19 institutions are involved in the study. Basically, it was designed likewise Optic. But because of the East Asian tend to underestimate in CAS score, so that the inclusion criteria for CAS and age has slightly arranged. The study has completed in 2023, and the result has come out in last August. This is a result of the proptosis reduction. After infusion, the proptosis reduced to 2.4 millimeter in Optic J, which was 1 millimeter smaller than Optic. But regarding to the anatomical difference in East Asian that I have presented before, I think it is a very good result. The diplopia responders are also similar to the Optic. More than 60% of patients improved more than 1 grade in diplopia score after the infusion. Next, the improvement of GOQOL. This was also similar to Optic, that the score improved 17 points from baseline in both studies. The safety profile of the Optic J was also similar to Optic. Infusion reaction was observed in only 1 patient, which was not critical, followed by hyperglycemia in 6 and hearing impairment in 4. All side effects were not severe, but the hearing impairment is a hot topic in the Optic study. So our 4 cases of the adverse event were not severe, that only 1 patient with infusion reaction discontinued the study. So overall, the Optic J has revealed that the effect and safety of the teprotumumab for East Asian patient is similar to that of Caucasian. In addition, the teprotumumab for chronic TED has been studied in the US, and inclusion criteria for chronic TED was arranged as 2 to 10 years of history of TED, CAS below 1, at least for at least 1 year, and stable thyroid status. The results show that a 2.4 millimeter proptosis reduction that providing teprotumumab can be effective for chronic TED as well. So now Optic J for chronic TED is running and will complete in a few years. So as a take-home message, an understanding of ethnic and anatomical variation in TED enhances clinical management. Teprotumumab used in East Asian TED patient is effective and safe, as well as Caucasian patients. That emerges as a pivotal treatment, offering a paradigm shift in TED care globally. Thank you for your attention.
Thank you, Dr. Mimura. Dr. Wu, if you would like to make any comments on the East Asian perspective of thyroid eye disease.
Congratulations on your result of the RCT on teprotumumab. It's my first time to see the result. I'm just waiting for your study, and then it's first time. So thank you for sharing the result with us. I did some epidemiologic study of TED in South Korea many years ago. And then I also found that the prevalence of the TED was lower than the Caucasian patients. And then age distribution is also different. We have 2 peaks on age distribution. 20 years of age is the second peak, and then the primary peak was on 40 to 50 years of age. So maybe that is very different from the Caucasian patients. And then also the proportion of moderate to severe eye disease is also less than the Caucasian patient. And then the most important thing in clinical evaluation is exophthalmos degree is different, as you mentioned in your study. So I was very anticipating your result because all the teprotumumab result was done on Caucasian and other patient, and then more specific study focusing on the ethnic population, different ethnicity has not been done. So congratulations on your study. And then you say that all the clinical responsiveness and then complication side effect is similar to the result of the previous study. Is there any specific one you think that the Asian people responded different, or that the kind of differences did you find? Please share with your thought.
Thank you very much, Dr. Wu. As I mentioned, I think there's nothing different from the Optic study, including the adverse event, also the hearing impairment too. So I think so it means like IGF-1R receptor is same as Caucasian in East Asian perspective, I think. Thank you.
Dr. Mimura, in the United States, now that we have 3 years of activity, of use of teprotumumab, we know that patients recur starting at 6 months after completion of their infusions. And so we end up having to decompress them even after they've had a good initial response. Do you have plans on doing long follow-up on these patients in Japan to see if that is similar in this ethnic population?
Thank you very much. I think I heard that they're happening in US, so we are planning to follow up for a longer period. Yeah, thank you.
Right. So we've had an excellent discussion thus far. Is Dr. Lelio Baldeschi here? Has he joined? Aarti, could you just quickly check? Till Aarti checks, I think he's had some trouble in joining us right now. And the topic we'd allotted to him was on postoperative complications in thyroid eye disease. And Dr. Anya Eckstein is the discussant for that topic. So, Dr. Anya, I think it's upon you and me to kind of probably have a rapid fire if Dr. Lelio is not able to join. So would you have any questions for the panel regards postoperative complications in thyroid eye disease? And we could just open it up for discussion with the panel over the next.
All right. Yeah, that's a very difficult topic to discuss within 10 minutes, I guess, with so many skilled operatives and other surgeons here in the group. But maybe we can focus on some issues. I would say for decompression, many very successful techniques have been established in the last 20 to 30 years. And I think there is an individual influence and also a technical influence. And maybe one of the very skilled operative surgeon can summarize this into 2 minutes. What is the advantage in lateral approach and medial approach under the different circumstances? I think we are all convinced that we have to do medical decompression when we have a patient with really enlarged muscles and apical crowding. And if we want to do on the other side, only the main aim is proptosis reduction, I think most of us go for lateral decompression. I don't know if there's an agreement. And I think there is also the fat approach, more maybe in the Asian population than in the European population. We could discuss on this as well a little bit.
Right. So probably one question, maybe a show of hands, in a patient where proptosis reduction is the main aim. How many in the group would opt for a balanced orbital decompression?
Depending on the aim, how much?
Right. So I see quite a few hands not raised. And then the next pertinent question becomes that what are your favored walls for decompression in where your aim is just proptosis reduction and you have a proptosis in the range of 8 to 10 millimeters to deal with, or say 6 to 8 millimeters to deal with, what would be the walls that you would address? Maybe, yes, Dr. Kahana.
So my go-to is the lateral decompression. And the CT scan will show how much sphenoid space there is. But if patients have a significant amount of sphenoid diplo and frontal bone diplo, then I go for the lateral decompression. I get a very good result from a medial decompression. The reason I do that is because in a medial decompression, you're actually encroaching on the normal anatomy of the patient because you're expanding the orbit into an area where the orbit normally would not be, which is in the sinus. Whereas with a lateral decompression, you're just thinning out the sphenoid and the frontal bone diplo to expand the orbit, but you're not actually going into a unique anatomic space. So I find that to be anatomically advantageous, but I get good results from either.
Yeah, that's a very good argumentation.
Right. So
Go
ahead, Dr. Don.
I was just going to point out that one of the arguments for lateral wall decompression or balanced decompression is that the studies by Bob Goldberg saying that medial and floor decompressions lead to a very high incidence of strabismus. And I think there's flaws in that conclusion because if you look at the series, the cases that they did that were medial wall and floor were largely done for optic nerve compression. And those patients had swollen muscles. Some of them had diplopia to start with. And anybody that didn't fall into that category and that had fat expansion and not so much muscle involvement, they did balanced decompressions. And I think that's where the difference is in the outcome with diplopia. I do a lot of medial wall and sometimes partial floor decompressions in patients that I'm doing purely for proptosis. And as long as they don't have diplopia to start, and as long as they're in that category of more fat-centric disease, and the indication isn't to try to relieve apical decompression, the incidence of new onset diplopia is extremely low. We actually reviewed a large series and it was less than 3%. So I'm fairly comfortable. I think you have to pay attention to the indication or make sure that the indication is balanced and the phenotype of the patient is balanced. Because many of the studies that find differences are picking one procedure for a phenotype and another procedure for a different phenotype. And of course, that's why the conclusion comes out the way it does.
Yeah, I totally agree with you, Peter.
Tijani, how are we going for time? Because I have about a 5-minute presentation on complications of orbital decompression, if that would fit in. But if we're going behind time, I'm happy to just proceed.
We are actually behind schedule, but if we have time at the end, after the 3 case presentations, probably we'll take that up quickly. Just to summarize this part, we've discussed about balanced versus unbalanced, and we don't have the verdict there. It's still a large amount of personal preference and surgeon's choice and comfort with the approach. The second question, leading question here was, when you consider a medial wall, you've decided for some reason that you're only going to address the medial wall. Would the group feel that an endoscopic medial wall is definitely advantageous over the transcaruncular orbital approach?
No.
No, I think that any approach, if you know what you're doing, any approach can be very effective. And to reduce the risk of induced diplopia, I think it's just important to leave the very anterior part of the walls intact so that we are not interfering with the pulleys of the muscles. The real decompression is done behind the eye, not in the front of the orbit. And so, that achieves axial proptosis reduction and does not impact the muscle pulleys. But I think that the details of the surgical approach are less important than the targeted decompression and the skill of the surgeon.
And the pre-existing muscle thickening counts as well. So if the muscles are already shrink, they tend to, then you have a significantly higher tendency of inducing motility impairment after decompression.
Right. So probably the last question here, since we spoke about muscles, so logically or intuitively leading on, there have been reports and series published where following decompression, a thickened muscle tends to enlarge and occupy the space that you've created by decompression. So does the group here tend to treat these myogenic patients differently following decompression to avoid the muscle swelling up?
I think
So
there are
I've
two
done.
mechanisms. I'm sorry, no, Peter, go ahead.
Oh, please go ahead, Anya.
Yeah, I think there are two mechanisms of muscle enlarging after decompression. One is just that we have a stretched, pulled muscle and it's thickening a bit if it is relaxing. So just the belly is a bit larger. This is only mechanical. And then you have really inflammatory processes after decompression. When you do decompression in an active phase of the disease, so the mechanical injury during the decompression induces more inflammation postoperatively, and that contributes to thickening as well. And these are the patients who need anti-inflammatory treatment and orbital irradiation after decompression right away. And I think Peter is nodding with the head. So, yeah.
Intraoperatively, I inject Kenalog and dexamethasone into the lacrimal gland, and that seems to help a lot with the postoperative inflammation.
That's
and I
a
don't
very
see
good
the kind
aspect.
I don't see the kind of expansion of the muscle size after decompression that's been published. And the second thing is that I've had really good results, promising preliminary results in combining teprotumumab with orbital decompression for exactly this sort of a situation where you have an active patient. We give them teprotumumab, and while they're on the infusions, we do the decompression, and they seem to do really well. At least I don't quite have a year follow-up on some of these early patients, but it's getting close to that, and so that could be a promising way of combining therapy.
Perfect. All right. So for the want of time, we'll take the 3 case presentations that we have and then come to a conclusion at the end with succinct points that we've learned from each talk. I have with me promising new kids around the block. The first one here is Dr. Blanche Lim, who's completed her training in Singapore. And she's going to present an interesting case situation today. And again, we have Dr. Anya for the discussion of the case. Go ahead, Blanche.
Good evening. I won't hold everyone back for too long. I'd like to thank the committee, Dr. Ganga and Dr. Tajani, for the very, very honored opportunity to share a bit of our experience. And I have here a very interesting presentation to share with everyone today. So we have with us a 15-year-old Chinese girl who was referred to us 4 years ago to rule out thyroid eye disease, following the clinical diagnosis of thyroid disease with prominent eyes, according to her, abnormal thyroid panel, and a positive anti-TPO antibody. She was commenced on carbimazole and propranolol. There was no family history, and she was previously well known. One thing to note is her father's a smoker, but because of familial issues, she does not stay with her parents at all. Now, 1 year prior to presentation, she was noted to have prominent eyes and was advised eye drops elsewhere, and had noticed a progressively left prominent eye with a right droopy eyelid. I will show the photos later. Otherwise, she denied any diplopia, no eye pain, no ache at rest or with movement, no diurnal variation. Systematically, she had been complaining of heat intolerance and tachycardia, and she had been commenced on carbimazole and propranolol. On examination, we noticed vision was actually perfect, 6.6. Intraocular pressures were normal tensive at 60 millimeters mercury in both eyes. Ishiharas were full. Pupil examination as well as optic nerve examination was otherwise normal and unremarkable. There was no obvious retroorbital pain, neither was there any significant swelling of the caruncle nor the eyelids. Her anterior and posterior segment was normal. Significantly externally, as shown in her photo here, we can see a right partial ptosis that's not covering visual axis, in contrast to a left upper eyelid retraction. I have attached as well ocular motility pictures on the next slide, which demonstrates a slight abduction deficit on extreme horizontal gazes. And she did complain of diplopia then. There were no hypometric saccades and there was no legophthalmos. And these were her exophthalmometry findings with a slight proptosis, a slight increase in the measurement of the protrusion of a corneal apex in the right compared with the left. So here we have the motility, the 9-gaze motility photos of our patient in question with a bit of an abduction limitation in the left more than right, and we thought it was likely secondary to moderate inactive thyroid eye disease. She was significantly not complaining of any other features, and hence on her first visit, she was given a clinical activity score of 0. This is also a photo of a woman view, and this is in comparison to her younger photos, which actually shows a significant difference from her at 9, 10 years old, 6 months prior to presentation, and at presentation itself. So we have here a trend over the course of the next 1 to 2 years. Significantly, her antibodies were remarkably elevated. A TREP that was done at presentation was found to be 15.5 elevation with an anti-TPO at 243. She was hence started on carbimazole 5 milligrams daily. We wanted to just highlight her CT scan findings, which actually shows an enlarged levator complex in the left compared with the right. And this can also be seen on the axial cuts as well in the very first column here. Now, 3 months after her initial diagnosis, she then herself noticed diplopia on leftward gaze in clinic, and she started to be bothered by asymmetry. With the left lid lag with retraction as well as abduction deficit, we hence offered her, and in view of the CT scan findings that returned to us, we offered and we proceeded with left eye intraorbital steroids. And for this, we did that on that same sitting with 20 milligrams triamcinolone to the superior orbit. This was her thyroid panel, which was then noted as well back then. 1 month after she returned for review, she felt much better after her initial injection. She in fact felt that her eye was feeling a lot less swollen. On measurements by Moritz exophthalmometry, there was still about a 1 millimeter difference. She was also feeling that her left upper eyelid retraction was a bit better, and this can be seen actually on her photographs, with an improvement in her lid lag as well. Motility was now full. We hence decided to continue to offer her second cycle of intraorbital steroids, for which she proceeded to her left superior orbit. Over here, you notice that she was also still struggling with a fluctuating thyroid panel at this point in time, with a free T4 of a slight elevation of still that was coming down to 5.6, a TSH of 1.32. Now, she returned to us at 1 month after, and she then felt that since everything had settled and she had no ocular complaints, she refused her third dose of intraorbital steroids. And with every 4 to 6 monthly review for her, for the 1 to 2 years after her diagnosis, she remained relatively asymptomatic with no ocular complaints. Her exophthalmometry readings had now come down nicely to 22 millimeters bilaterally, with a bit of trace left upper eyelid retraction with lid lag. Now, the only thing was with her on carbimazole 5 milligrams 4 times a week, and her TREP coming down from 1.5 to less than 1, even undetectable. 2 years after her initial presentation, she was then noted to have had a bit of palpitations as well as weight loss again, and they had found with her thyroid panel that she had relapsed. Her TREP levels were now elevated at 20. Free T4 had gone up to 31.1, and her TSH undetectable levels. She was hence commenced on carbimazole 12.5 milligrams daily, but with the fluctuating thyroid panel as well as the TREP antibody levels that were still downtrending as with the subsequent reviews, she has remained asymptomatic since. Which hence brings me to 3 questions. The first would be the prevalence of silent active thyroid eye disease. We know that this has been described and has taken particular interest for us in the past 2 years to 4 years. And I think one thing we need to ask ourselves is this something that's underdiagnosed and recognized? The second thing that we note here is that even though TREP here was done alone in the initial phases together with an anti-TPO, we wonder about the synergy with other antibodies and the fact that TREP levels may not downtrend and stay low and may rise in a case of a patient who relapses, and its correlation with the clinical picture. The other question we have is the option of intraorbital steroids. When would one consider such an option? We know that papers have also been coming out with regards to this. But the question here is this an underutilized practice in contrast to the offering of something that's more systemic? And especially with our friends using targeted therapies on the block, is this something that we could still go and revert towards? Thank you very much. I'll just go back to the 3 questions, and I think our panel will take the floor as well.
Thank you so much for your nice case presentation. Really, really good. And you really raised very interesting questions. And I think I have the choice to give first my answers, and then the panel is, I think, jumping into the discussion. So I think silent clinical chat may not be silent on the molecular level. So there are all these pathogenetic processes taking place on different amounts. So, and it's just a proof retrospective. If steroids work, there must have been some inflammatory processes in the lid, and therefore it works. So that brings me to the third question: is this underutilized? I think yes. And I think, yes, we would need clinical trials on this, especially there are some, but maybe there should be maybe more with special patient selection. And yes, in children, the thyroid disease tends even to relapse more often than in adults. So the remission rate in children is about 25% in comparison to adults, where it's about 50%. So there's no surprise that there is a relapse. And concerning TPO antibodies, they occur in about 50 to 60% in patients with thyroid eye disease, as well in Hashimoto's disease. It's just a sign of thyroid autoimmunity, another sign of thyroid autoimmunity. So that are my comments to your very nice case presentation, and I really think that the panel would like to discuss this too.
Yeah, we'll take one quick comment from the panel, if any, before moving on to the next case. We have 10 minutes to wrap up our session.
Dr. Tarjini, I'll just interrupt in between. We were supposed to end this session at 3:10, but I see that the session is going on very interesting, and we want you to continue the discussion. So just a quick announcement for our audience. We'll be having our next session on Asia Pacific Glaucoma Society Symposium, Recent Advances in OCT Imaging for Glaucoma, which we will start at 3:15 in Hall B. And the discussion will be continued here in Hall A. Over to you, Dr. Tarjini.
Thanks so much, Aarti, for that extra time. Go ahead, Surya.
Okay, just very quickly, number one, I think this particular case was very interesting, but there were also pointers towards utilizing intra-lesional or intramuscle steroid. Number one, this was a young patient. There was a little bit of a history about smoking, but she wasn't, I mean, that was not really a risk factor, and there were no other risk factors. I think based on that, there was a fair prediction that this particular patient was unlikely to go into a much more severe disease. And having said that, on the underutilization, actually a lot of, I think over the last, I think less than a decade or maybe 5-6 years, there's been a lot of literature and use of intralesional steroid for eyelid retraction, and the results are very attractive. So
yeah. There is a little dependence on the frequency, I guess. So you can use it and twice or 3 times, but after the 3rd time, you may have more complications. So Peter, you would like to comment on it, I guess.
Well, just to say that I don't think it's such a rare event. I mean, I think in my practice, 2/3 of patients are younger women that present with prominent eyes and or lid retraction that never had any positive high CAS score. I mean, they have an indolent onset of gradual expansion, and clearly they must have been active. And that's why I always argue that CAS is inaccurate in 2/3 of my patients. historically, because there was active disease, and they can tell you they never had swelling. Sometimes they'll have swelling in the upper lid as the lid retraction is developing, and I find that correlates with enhancement or edema in the levator muscle, and those are probably the patients, I'd agree with Surya, that would be prime candidates for intralevator or perilevator Kenalog injection rather than just intraorbital. And I'm not convinced that intraorbital steroids itself prevents proptosis, so I wouldn't give it for that purpose.
How often would you repeat it, Peter? How often would you repeat it?
Kenalog injection in the levator, I just give it once.
Yeah.
And I mean, I like the surgery too, and it's fast and works, but I think the steroids do work if you see some edema or evidence on imaging.
Dr.
I just want to say that I put in my a paper in the chat for anyone to download that we just published on Kenalog dexamethasone injection in the orbit.
Great. Thank you, Dr. Sahana. Dr. Dolman, just two yes or no questions to you, because you also spoke of imaging. So would you image a patient before giving orbital steroid to see if the levator muscle is thickened? And if you see it is thickened, then consider steroid? Would that be a yes or a no?
Yes.
And
yes.
if you, fantastic. And say this patient, hypothetical patient has had eyelid retraction for a long period of time. You do not see levator muscle thickening, concerned about the lid retraction. In that case, would the choice be a filler agent or a botulinum toxin or surgery?
No, I mean, I think if it's long-standing, first of all, I think if I see long-standing lid retraction in a patient with thyroid eye disease, I'm going to see an enlarged levator. I mean, if you look for it, you'll find it. And if it's long-standing, I would just go for surgery. I think lowering the lid is a predictable surgery. It's very fast, it's gratifying, and I use a posterior approach. Where I just insert the levator, but that would be my approach. I don't really use fillers, and I'm not convinced Botox makes sense if you think it's scarred. But I've had no experience with Botox, so I shouldn't say.
Right. Thank you, Dr. Dolman. For the want of time, we'll quickly move on to the next case presentation by Dr. Sumer Doctor, our young and dynamic fellow at LV Prasad Eye Institute, who hails from Mumbai, the city of dreams, the city that never sleeps. He is going to talk to us about a case on dysthyroid optic neuropathy. Go ahead, Sumer.
Hello, everyone. At the outset, I'd like to thank Dr. Santosh, Dr. Tarjani, and Dr. Ganga for this opportunity. My topic for today is dysthyroid optic neuropathy. What's next? So here we have the story of this 52-year-old gentleman, a known case of hyperthyroidism with a history of prominence of both eyelids along with painful eye movements since the last 3 months. He's a non-smoker and he is not diabetic and has no known systemic illnesses. He's already received 6 pulses of 500 milligrams of IV methylprednisolone and has come to us for a second opinion. As I said, his examination revealed both eyes proptosis as well as chemosis and exposure keratopathy in the right eye. His clinical activity score on presentation was 7 on 7, and these are the pictures of the patient. So on the intraocular examination, the visual acuity was 20 by 125 in the right eye and 20 by 80 in the left eye. His color vision was diminished in the right eye. He had an intraocular pressure of both eyes of 25 millimeters of mercury, and he was not on any anti-glaucoma medication. His fundus evaluation at presentation was within normal limits. He had come with a perimetry, which revealed a superior arcuate scotoma in both eyes. So here we have a patient who has sight-threatening thyroid eye disease in the right eye, as well as components of right eye exposure keratopathy and dysthyroid optic neuropathy. An initial conservative line of management was opted for. Anti-glaucoma medications were started for the patient, and a pulse dose of 1 gram intravenous methylprednisolone was given over 3 days, totaling 3 grams of IVMP. This is the patient's photograph after IVMP, 3 doses were given. The proptosis has significantly reduced and there is a significant reduction of inflammation as well. However, the patient happens to be a steroid responder and he also has systemic complications of the intravenous methylprednisolone. And he has also not shown any improvement in visual acuity. He came back to us 6 weeks later with an apparent increase in inflammation once again in the right eye. We can see the inferior chemosis. And we decided to restart the intravenous methylprednisolone, but this time it was given over 6 weeks and it was given in pulse doses. Post the intravenous steroids, this time the patient did not have much reduction in the inflammation. The symptoms of exposure seem to persist and the inflammation has not gone down. So this patient has presented once again with a suboptimal response to the intravenous methylprednisolone. With this in mind, we decided to take the patient up for external beam radiation therapy to bilateral orbits. A total dose of 36 gray was given in 12 fractions to the patient. This is the photograph of the patient post 6 weeks, and he's shown a good response to radiation as well. And he's also shown an increase in the extraocular movements. The vision in the right eye improved to 20/50, and in the left eye has improved to 20/25. However, he has persistent disc edema in the right eye. He came back to us 6 weeks later, and he had a quiet phase for about 6 weeks, but he returned with a progression of inflammation and a clinical activity score of 8/10, and we decided to repeat imaging. These are the CT scans of the patient. We can see bilaterally thickened extraocular muscles with an increased more than 75% effacement of fat in the right eye, bilateral optic nerve stretching and tenting of the eyeball in the right eye as well. Considering the suboptimal response to the conservative management, the patient was planned to undergo sequential orbital decompression. This is the patient after sequential orbital decompression. The left eye has just been done 1 week back. And he's showing a good response to the decompression. And this is the patient's photograph that was sent to us 2 years post-surgery. And he's doing well. So with this, I'd like to ask a couple of questions to the panelists. What would the role of OCT or any newer imaging be in detecting dysthyroid optic neuropathy and gauging its progress? And stretch optic neuropathy, as has been mentioned before, does it have any solution apart from surgery, or is that the only options we have? Thank you.
Well, I think teprotumumab is a good option, potentially, if you have access. This is the kind of patient who should respond to teprotumumab, to anti-IGF-1 receptor pathway.
Right. So probably another caveat here, since this patient was managed by me partly, the patient was not fit for surgical orbital decompression. He did not have fitness for general anesthesia. So now, given that situation, and you have sight-threatening thyroid eye disease, and you do not have teprotumumab in our part of the world, what would be the options for a patient like that?
Well, just a couple of comments. I think this is a very challenging case. I can't really recollect, was this patient a diabetic or not a diabetic? I don't remember whether...
He was not a diabetic to begin with, but following the steroid treatment that he received, the methylprednisolone, he was detected to have high blood sugar and then started on treatment for diabetes mellitus.
Okay, well, I think essentially, apart from the fact that he was, he was a 52-year-old and was a very high CAS scores, also dysthyroid optic neuropathy. Essentially, one of the things that happened, that there was a response, is a typical scenario where there was a response to intravenous corticosteroids, but this was not a sustained response. And this is something we often see. In addition to that, there was a spike of the blood sugars. Essentially, under these scenarios, I think in some of the follow-up pictures, I also noticed that he started developing corneal breakdown, especially in the right eye. Assuming that there was not a problem with the general anesthesia, I think my preferred choice in this would have been probably to think about decompression or medial wall decompression and look at a sustained response with possibly adding radiation. If the patient was not cleared for general anesthesia, then that's definitely a challenge. But I think sometimes the right eye was more at risk. And sometimes in scenarios like this, it's worthwhile to talk to the anesthesiologist that you could probably do something like a minimally invasive, essentially try to do a very short surgery with the medial and the inferior wall that would probably take care of the compression. And particularly what we see is the stretch optic neuropathy. The second question is more relevant. I think that constitutes about 10% of the optic neuropathy that we see. And unfortunately, that particular group is the one which only seems to respond to surgery. And surgery is one of the first choices whenever you face a situation of stretch optic neuropathy.
Right. Thanks, Surya. So for the want of time, we'll move on to the last case presentation. And this is by Dr. Kirti Koka, who's a faculty at Shankar Nethralaya in Chennai, the land of beaches, the land of temples. So Kirti, the stage is all yours. She'll be presenting a case on a difficult eyelid in thyroid eye disease.
Thank you, Dr. Tarjani, for the invite, for giving me this opportunity. I want to thank Dr. Ganga and Dr. Munawar and the entire AIOS team. It's been a wonderful session so far. So my topic is a difficult eyelid. This is once we deal with all the medical aspects of thyroid that everyone has spoken about, this is the one thing that we land up with, which is a patient with a lid retraction. So I have two cases here to discuss. So this is a 46-year-old lady. She presented to us with inactive thyroid eye disease. As you can see, she has an upper lid retraction, she has a lateral flare, and also an inferior scleral show. Imaging showed an inactive disease, and hence she was very particular. She wanted to get this lid retraction treated. She was not particular about her lower lid retraction. As you can see, she has a very minimal lag of ophthalmos here. So we decided to go ahead with a well-tested procedure, which is going to be the anterior blepharotomy, full thickness. So we went ahead and did a full thickness blepharotomy. A skin incision was made. The orbicularis is dissected. The tarsal plate was exposed. We marked the center point. And then we went ahead and did a full thickness incision along the upper border of the tarsus. The lid height was checked on table. We noticed that there was still a little bit of retraction persisting with the lateral flare. So we went ahead and dissected the lateral horn of the LPS. When we found the correction to be okay, the skin incision was then closed with 6-0 ethylon sutures. This is the patient immediate post-operative period. As you can see, the lid position is good, but there is a little bit of lid edema. And this is the patient at 3 months of follow-up. So here we can see that though there's a good correction in the lid retraction, she still has a little bit of retraction when compared to the other eye, though she has started off with a minimal ptosis in her left eye for which she was not keen on any particular surgery. Her lateral flare is also well corrected, but there is still that little bit of residual lid retraction. Now, this is another patient who has bilateral lid retractions, gross retraction of the upper lid and the lower lid with a lateral flare. She has a small amount of lag of ophthalmos in both her eyes. And as you can see, the imaging and MRI was done for this patient. Her muscle thickness doesn't show gross enlargement. And even there's not much of fat and increase in the amount of fat. So here her features are more just of an upper lid and lower lid retraction. So here, because the patient was keen on correction of both the upper lid and lower lid retraction, we decided to follow this technique by Dr. Susan Freitag, where you harvest upper tarsus from the upper lid, and this tarsus, which is harvested, is used as a spacer graft for the lower lid, and at the same time, you can recess the upper lid retractors. So we went ahead and did a full, harvested a tarsal graft, free tarsal graft from the upper lid. And at the same time, we recessed the muller and a little bit of levator. A graded recession was done assessing the lid height on table. The harvested tarsus was then placed in the defect that we created in the lower lid below the lower border of the tarsus after retracting the inferior retractors and was sutured into position. So this is the patient pre and post the surgery. You can see that there is a very good correction in the left eye. But in the right eye, she still does have a little bit of residue upper lid retraction with a little amount of lateral flare. So my questions here to the panel is, no matter what we do sometimes in patients with severe lid retraction, no matter what the choice of surgery, we do always end up with a little bit of residual retraction, or the retraction tends to recur with time. Though in the immediate post-op period, they tend to do really well, but with time, they tend to recur. So what is the panel's choice of surgery for such cases? Any experience with the use of alloderm rather than using tarsal grafts or scleral grafts, use of alloderm as a spacer graft? And in patients who are having severe lid retraction, and if a decompression surgery is planned, would you still prefer to do decompression surgery first and then the lid retraction surgery is the next sitting? Or can they both be combined as a single sitting so it is beneficial to the patient too? Thank you.
Is there a specific discussant for this, Dr. Dami?
Dr. Couch, you are discussing this case.
Okay, so for me, I would not consider decompression and eyelid surgery in the same setting. I do them as sequential surgeries, with obviously eyelid surgery being the second surgery. Some of your two patients both had eyelid retraction, but they also looked proptotic, especially the first patient that you presented. And so I was wondering what the exophthalmometry measurements were on that first case, and potentially could orbital decompression surgery have been considered? As far as using alloderm as a spacer graft, I have not in this setting, but sclera and hard palate mucosal grafts have been some of my more common ones. I'll open up for anybody else to have any other thoughts or discussion points for this.
Any thoughts on spacer grafts for the upper lid retraction as such?
So the alloderm you were asking for upper lid, I thought you were asking it for the lower lid.
For the lower lid, yes, but for patients with severe retraction in the upper lid, the role of spacer grafts, because most often we tend to do a posterior recession, either molars, or in really severe cases, we also disinsert the levator. But has anyone tried their results with spacer grafts in such cases to prevent a recurrence?
I've never needed them. I've dealt with really bad retraction, and the upper lids, I've never needed them. Like Peter, I use the posterior approach, so you're not invading skin. You're not doing anything to the orbicularis, which is responsible for the closure. You're just going directly after the retractors with the posterior approach. And after a good decompression, not infrequently, the eyelid position improves. And then if you deal with inferior rectus restriction with a strabismus surgery, upper eyelid retraction improves as well. The lower lid after the inferior rectus recession can get worse, but the upper lid improves. And my preference for lower lid spacer is an ear cartilage graft because it has the rigidity. It's an autograft. It's easy and low morbidity to harvest. Alloderm goes away. It actually is not a good long-term spacer. It doesn't have sustained rigidity. And so I'm not a big fan of it in these situations. I think Peter has something that he would like to add.
No, I agree pretty much with everything. The only qualification I would make is, first of all, lower lid retraction. If it's significant, I will quite comfortably fix that retraction at the time of the orbital decompression. But always with an orbital decompression, keep in mind that if you're taking out any part of the floor, the upper lid retraction will probably get worse if the eye sinks a little bit, and the lower lid retraction will probably improve a bit. But I'm quite comfortable fixing significant lower lid retraction at the time of the decompression. But I agree with everyone on the panel that the upper lid, I almost never do, but there's an exception there too, that if someone's got bad exposure and corneal breakdown, I will be very comfortable doing the decompression and the lid retraction repair, because your goal here is to protect the eye and the cornea, and then you can always go back and refine the shape and the height with the secondary upper lid surgery if you need to. And I use, because we have an available donor sclera for the lower lid, but I think ear cartilage works well too. And for the upper lid, I've never put spacers in.
Peter, in your experience, how often do you need to go for an upper lid retraction repair a second time? For me,
well, we did sorry.
Yeah. In severe cases, sometimes I tell patients in advance, you may need more than one surgery.
Oh, yeah, we did a review of maybe 300 posterior approach upper lid retraction procedures, and the reop rate for secondary retraction is about 10%.
Yeah.
In my hands. So I warn the patient. I also would point out that I think the surgery we're doing, even though some people think it's related to the molars, I think I'm getting the result when I get to the levator and cut the levator. So for me, the thing that's lowering it is cutting through levator. And be very careful from, just like in an anterior approach, from a posterior approach, don't cut centrally unless you really have to, because you get a very flattened contour that's unsightly.
Thank you.
Dr. Kuka's surgeries went well, and then she has very good results. So I don't touch that kind of patient. I don't touch consider reoperation for that kind of patient. For the upper eyelid, usually we don't use any spacer for the retraction repair, but very severe, for example, radiated and then very severe scar. And then I had a couple cases with putting dermis fat graft, releasing all the scar tissue and then using the spacer material. That is my experience.
Thank you.
Thank you, Dr.
Just Tarjani, a quick comment that actually I think I would relate with Kirti, essentially that in the rare circumstance where the primary surgery for the upper eyelid ends up with a residual retraction, I would actually use a sclera as spacer and an anterior approach. So that's something that I do, not primarily, but when I face a situation like you did for that, yes.
Right. Thank you, everyone. We've had excellent discussion. Just wanted to summarize the session thus far. We had Colin and Dr. Kahana, who brought about the role of the orbital fibroblast as the criminal in thyroid eye disease. And Colin put forth aryl hydrocarbon ligand for the myogenic variant and AMP-activated protein kinase for the adipogenic variant of thyroid eye disease as potential drugs to look forward to. Dr. Dolman and Surya discussed about imaging in thyroid eye disease, imaging in diagnosing, in activity and severity of the disease, and in planning your surgery. And we all agreed upon MRI with gadolinium enhancement as probably the imaging of choice in patients with thyroid eye disease. We also had Dr. Tim Sullivan and Dr. Stephen Couch talk to us about targeted treatment. In the teprotumumab deficient world, probably tocilizumab seems to have more promise than rituximab as of now as subcutaneous injections. We had Dr. Mimura and Dr. Kungenbu speak to us about the Japanese experience with teprotumumab and possibly the ethnic differences given. We still might have good outcomes of teprotumumab once it's introduced to the world in a wider way. We also discussed about balanced versus unbalanced orbital decompression with the house divided on their approach. Medial endoscopic probably would not be giving us a much better outcome than transorbital. And we also discussed about giving steroids along or teprotumumab where available along with decompression for those thick muscles that you see. We had 3 interesting case presentations, one on the steroid injection intraorbital, which seems to be a promising new upcoming treatment option, especially for eyelid retraction. Dysthyroid optic neuropathy, where we discussed the role of steroid and radiotherapy along with decompression, and eyelid retraction, where we discussed several options, including customizing your decompression so that you can specifically target the upper or the lower eyelid. Thank you so much, everyone. And thank you very much, Dr. Honavar and Aarti, for giving us the extra time. And I cannot thank all the invited speakers probably in a better way. Thank you so much for being a part of this and sharing your knowledge. Until we meet again, stay safe. Thank you again, everyone.
I'll just request everyone to put on their cameras and give their best smile. I'll just take a official photograph, I'll say. Here we go. 3, 2, 1. So thank you, Dr. Tarjani, for moderating this session so very well. And the session was really very interesting and informative. So
thank you, Dr. Ganga. I see you here back again.
Yeah, a big thank you, everybody. I'm so sorry I couldn't contribute. Yeah.
Right. All right. Thank you, everyone. Signing off now. Bye-bye.